Welcome to the ACAP webinar, Introduction to Evaluation and Management Coding for the Child and Adolescent Psychiatrist. My name is Dr. Benjamin Shane. I'm a member of the AMA CPT Advisory Committee as the ACAP alternate representative. The two other members of the ACAP CPT code team are Dr. David Berland and Dr. Sherry Barron Seabrook. This webinar will show you that E&M coding is simple as well as fast and easy to learn. Well, not exactly. Reality check, mastering these codes will take you some time. You may navigate this webinar by moving your mouse cursor over the slide. Notice that a control bar appears. The button on the left side of the control bar toggles between pause and play. The three buttons on the right side control sound volume, viewing and hiding the active table of contents panel, and full screen view. I've been teaching use of E&M codes for years, but still remember the first time I saw the requirements. My thought was, how can anyone be expected to use these codes and document correctly? Not only is there an extensive array of requirements, but the decision as to what code to use and how to document must typically be made in seconds so as not to impinge on the already cramped time we have to see patients. So I recommend the following steps. Recognize that there's a lot to learn and you need to put in effort to do so. When learning, try to get the big picture first and go back and learn the details later. Cheat sheets that you carry around may be very helpful initially. Templates designed for your particular documentation system may also be helpful. Most providers end up using a small number of codes repeatedly. Once you learn the system, memorize what you need for the code you use multiple times every day. What are E&M codes? E&M codes are a collection of CPT codes that start with 99 and describe medical services of collecting and assessing information, planning treatment or further assessment, and prescribing and monitoring medications. These codes may be used by all physicians and other medical providers. They may be reported in addition to a procedure such as ECT, as long as the two services are significant and separately identifiable. E&M codes are not psychiatry codes, although they may be used by psychiatrists to report medical services. The most common medical service by a child and adolescent psychiatrist is medication management. Psychiatric procedures such as psychotherapy are different and are discussed in the webinar on the 2013 psychiatry codes. Why should a child and adolescent psychiatrist use E&M codes? For one, they reimburse more for the same service. A second important reason is that starting in 2013, most psychiatrists will not have any other way to report medical services. Again, these are not the easiest codes to use, with a reputation for being complicated, hard to document, easy to miscode, and vulnerable to audit. We want you to have the knowledge to code in confidence and believe these webinars will provide that. Let's get an idea of how reimbursement for E&M codes stacks up against equivalent psychiatry codes. There is a reward for using E&M. Medicare reimbursement for 99213 and 99214, which cover most outpatient medication management services, are both higher than that for 90862. Reimbursement for 99204 and 99205 are also higher than that for 90801. Medicare payment for 99213 is 20% more than it is for 90862. Payment for 99214 is 78% more. Payments from other third-party payers may be similarly more. A couple of words about documentation. The E&M documentation guidelines explain in detail what is needed for an E&M service. There are two sets of guidelines, 1995 and 1997. Any visit may be documented based on either 1995 or 1997 guidelines, but not a mixture. Child and adolescent psychiatrists should use the 1997 guidelines, as these are equal or better for psychiatric patients nearly all of the time. The rest of this talk is based on 1997 guidelines. Auditing guidelines, designed by CMS and refined by local Medicare carriers, go further into detail. The next slide gives an example of complete documentation for a visit note. Well, maybe there's still a few details missing. There are multiple purposes for documentation. These include treatment planning, immediate and over time, continuity of care with other providers, utilization and quality tracking, and collection of data for research and education. This presentation only addresses what is needed for claims review and payment. Consider the documentation recommendations in this webinar to be necessary for reporting E&M services, but not sufficient for the multiple other purposes of medical documentation. General principles of documentation are basic but often overlooked, so the note should be complete and legible, and include the reason for the encounter, relevant history, examination, test results, assessment, diagnosis, plan, date, and identity of the writer. Rationale for orders, relevant past and present diagnoses, health risk factors, responses and changes in treatment and diagnosis, and support for CPT and diagnosis codes should also be noted. Some auditing issues. Upcoding refers to coding a level of service above what is supported by the documentation. Downcoding is selecting a code lower than what is supported. Downcoding is not an audit problem per se, but may result in significant loss of revenue sacrificed so that the provider feels that he or she is safe. Documentation must support E&M criteria and must also support medical necessity for the service for the particular patient at the particular time. There is less safety and less reimbursement in downcoding than there is in correct coding and documentation. A couple of red flags that can trigger an audit include high use of the highest level code in a particular code family and exclusive use of just one code in the family, even if that code is middle or low level. This red flag applies to services that are high volume and expected to have variation, such as follow-up visits for outpatients and inpatients. There are 92 evaluation and management codes divided between various families and levels. Most of the E&M codes are divided into sets or families determined by site of service and patient status. Office visit codes, for example, are divided into new patient, 99201 to 99205, and established patient, 99211 to 99215. Hospital visit codes are divided into initial, 99221 to 99223, subsequent, 99231 to 99233, and discharge, 99238 to 99239. There are also separate codes for outpatient consultation, 99241 to 99245, and inpatient consultation, 99251 to 99255. Most code families have multiple levels specified by the fifth digit of the code, which commonly defines 3 or 5 levels depending on the family. Most of the rest of this talk focuses on how to choose and document the appropriate level. The level of the E&M code is determined by 7 components. The first 3, history, examination, and medical decision-making, are called key components, as these components typically determine the level of the code. There is an exception when counseling and coordination of care are greater than 50% of the time of the visit. If so, the level of the code is determined by time. Nature of presenting problem is listed as a component and mentioned in the code descriptions themselves as a guide. 2 other factors, not formally E&M components, are also important in determining the level of the code. These are the type of appointment and medical necessity. The type of appointment, such as addressing an acute problem, following up on care for chronic problems, or reevaluation after a gap in treatment, has a major influence on the work conducted during the visit. Medical necessity is a requirement for all medical services. To meet medical necessity criteria, consider the nature of the presenting problem and the type of appointment. For most visits, the complexity of medical decision-making is an excellent guide to whether the level of the visit is medically necessary. The rest of this webinar focuses on these various E&M components. I'm now going to summarize the three key components: history, examination, and medical decision-making. We will then go into each in detail. History is divided into four elements: chief complaint, history of present illness, past, family, and social history, and review of systems. Except for chief complaint, the elements also have elements. There are actually 12 different kinds of physical examinations, any one of which may be used to meet the requirement for examination. Any physician may use a general physical examination or any of the 11 single system examinations designed for various specialties. Child and adolescent psychiatrists should use the psychiatric single system examination, which spans 3 organ systems: constitutional, psychiatric or mental status, and musculoskeletal. Details will be explained in a few minutes. Medical decision-making has 3 elements: number of diagnoses or management options considered, amount and/or complexity of data to be reviewed, and risk related to presenting problem, diagnostic procedures ordered, or management option planned. This will also be explained in detail in a few minutes. Now for history. History has 4 elements: chief complaint, history of present illness, past, family, and social history, and review of systems. Chief complaint is required for all levels of history. Chief complaint states the reason for the encounter, either from the provider perspective or the patient perspective. You may give symptoms, such as listing the main symptoms, or something like, "I cry too much," or give process, such as, "This is a follow-up visit for," or "My mother told me to come." The HPI is a description of the patient's illness. This includes information that is addressed at the visit, not what is in other parts of the chart. Up to 8 types of information about the illness are specified. CMS refers to these types of information as elements of HPI. The elements are location, which refers to the areas of the body or organ system affected. Emotional and behavioral are examples of a psychiatric location. Quality refers to a description of the symptoms, such as sadness. Severity is self-explanatory. Duration refers to the entire course of illness, such as the first signs of depression were 5 years ago. Timing refers to temporal course of symptoms, such as continuous or intermittent. Context is a description of what else went on with the start of the illness, such as depressed after breaking up with boyfriend, or with symptoms such as anxiety around people. Modifying factors are those that appear to get the symptom better or worse, such as, "I feel better when I meditate," or "I have more negative thoughts when I'm alone." Associated signs and symptoms are other symptoms of the illness, such as, "I have trouble falling asleep." The HPI elements do not need to take a lot of space. This slide provides an example of all 8 elements documented in one sentence. The patient reports intermittent, that's timing; emotional, that's location; problems of moderate, that's severity; sadness, that's quality; starting with a romantic breakup, that's context; 6 months ago, that's duration; now more so when alone, that's modifying factors; and associated with poor sleep and appetite, that's associated signs and symptoms. HPI is either brief, 1 to 3 elements, or status of 1 to 2 chronic conditions, or extended, 4 or more elements, or at least 3 chronic conditions. The next element of history is past, family, and social history. Past history refers to the patient's past or other medical conditions and treatment. Family history is also strictly medical, referring to relatives. This may include relatives' current health status. Social is the rest of the patient context, which may include substance use, grade in school, who lives at home, or a favorite hobby. Only one item is needed from each of these areas to meet criteria for documenting the area. So, for example, patient lives with both parents documents social. Past family social history is either pertinent, item from one area, or complete, item from 2 areas for established patients or from all 3 areas for new patients. For review of systems, CPT recognizes these 14 organ systems. There are three types of review of systems. Problem pertinent is one system related to the problems in HPI. Extended is 2 to 9 systems. Complete is 10 or more systems documented, or systems with positives or pertinent negatives documented, and a statement such as, all other systems reviewed and are negative. Without such a statement, at least 10 systems must be documented individually. This chart puts it all together to arrive at the level of history, with the level being the one that has all three elements met or exceeded, plus a chief complaint. So, problem-focused history includes brief HPI and no need for past family social history or review of systems. Expanded problem-focused history includes brief HPI and problem-pertinent review of systems with no need for past family or social history. Detailed history includes extended HPI, pertinent past family social history, and extended review of systems. And comprehensive history includes extended HPI, complete past family and social history, and complete review of systems. So, you got that? This may be an easier way to visualize the same chart. To remember, keep in mind that problem-focused and expanded problem-focused require HPI with at least one element or chronic condition, and detailed and comprehensive require HPI with 4 elements or 3 chronic conditions. There is no past family social history until you get to detailed, and then it is 1 for detailed and 2 or 3 for comprehensive. Review of systems goes 0 for problem-focused, 1 for expanded problem-focused, 2 for detailed, and 10 for comprehensive. Okay, maybe that's not any easier. Remember, though, that back in the day, you all learned neuroanatomy. On to physical examination. Physical examination may be a general exam or one of those single system examinations. CPT recognizes each of these systems as being equivalent to a general physical examination performed by a primary care physician. Hence, the single system psychiatric examination presented next counts the same as a general physical. The psychiatric single system examination has 3 parts, the first being constitutional. By the way, shaded box or border describes the original appearance in the CMS publication. Whether the item is shaded becomes relevant a little later. Each element of the examination is referred to as a bullet, with constitutional having 2 bullets, 3 or more vital signs, and general appearance. The items listed under general appearance are examples of that description. The items listed under vital signs, however, are the actual required vital signs. To meet the vital signs criterion, you need to include at least 3 of the 7 listed vitals. Those are sitting or standing blood pressure, supine blood pressure, pulse rate and regularity, respiration, temperature, height, weight. The second part of the examination is musculoskeletal. Unshaded box again refers to how this is presented in the 1997 guidelines, and that only one of these bullets is required for a comprehensive examination. The 2 bullets for musculoskeletal are muscle strength and tone, and gait and station. The bulk of the examination is mental status, although a bit different from what most of us have been taught. In particular, thought is divided into 3 bullets. Thought process, including rate of thoughts, content of thoughts, for example, logical versus illogical or tangential, abstract reasoning, and computation. Associations, for example, loose, tangential, circumstantial, intact, and abnormal or psychotic thoughts, including hallucinations, delusions, preoccupation with violence, homicidal or suicidal ideation, and obsessions. Again, shaded box or border describes the original appearance in the CMS publication. Whether the item is shaded becomes relevant a little later. This is what the psychiatric examination looks like in the 1997 guidelines. Note the shaded border for constitutional, the unshaded border for musculoskeletal, and the shaded border for psychiatric. The psychiatric examination has 4 levels: problem-focused with at least 1 bullet, expanded problem-focused with at least 6 bullets, detailed with at least 9 bullets, and comprehensive with all the bullets in the shaded boxes, constitutional and psychiatric, and at least 1 bullet in an unshaded box, musculoskeletal. Now what you've all been waiting for, medical decision-making, the key of the key components. Medical decision-making has 3 elements: number of diagnoses or management options, amount and/or complexity of data to be reviewed, and risk. 2 of these must be met or exceeded for a particular complexity of medical decision-making. Those elements are those that are addressed at the visit or with tasks such as phone calls associated with the visit. In other words, medical decision-making refers to the work that you do currently. CPT and the CMS guidelines describe what is needed for determining the level for a number of diagnoses or management options. I'm not even going to read this description, as it is too ambiguous to determine the level. The names of the 4 levels are also not particularly specific. CMS recognized the specificity was lacking for determining the level for a number of diagnoses or management options, and so released voluntary auditing guidelines to the local Medicare carriers. The carriers have very similar adaptations of the auditing guidelines. The one in this presentation is by the carrier Wisconsin Physician Services, WPS, and is the most conservative. The way the table works is the level of number of diagnoses or management options is determined by the sum of the problem points for the diagnoses and/or problems addressed during the visit. Each problem is assigned 1 to 4 points, and the points are added together to obtain the total problem points. The self-limited or minor category maxes out at 2 problems or diagnoses, and the new problem, no additional workup category maxes out at 1 diagnosis or problem. In other words, for each minor problem up to 2, you get 1 point. For each stable established problem, no limit, you get 1 point, etc. The points are totaled to come up with the problem points. A couple of notes. 1. Ordering use of a psychiatric rating scale after the visit qualifies as additional workup. And 2. Problems addressed during the visit may include those under the care of another provider, such as medical comorbidities, but important in the evaluation and management of the problems under your care for that visit. For example, you are likely not treating the patient's diabetes, but this illness is important in your management of the patient's bipolar disorder. In that case, you may include diabetes as a problem. The number of problem points determines the level for the number of diagnoses or management options, with the highest level achieved at 4 or more points. CPT and the CMS guidelines describe what is needed for determining the level for amount and/or complexity of data to be reviewed. Again, I'm not going to read this, as the description is too ambiguous to determine the level. Also, the names of the 4 levels are not particularly specific. Similar to what it did for number of diagnoses and management options, CMS recognized the specificity was lacking for determining the level for amount and/or complexity of data to be reviewed, and so released voluntary auditing guidelines to the local Medicare carriers. The carriers also have very similar adaptations of the auditing guidelines, and again, the one in this presentation is by the carrier Wisconsin Physician Services, WPS, and the most conservative. The way the table works is the level of amount and/or complexity of data to be reviewed is determined by the sum of the data points for the data to be reviewed associated with the visit. Each category that applies has 1 or 2 points, and the points are added together to obtain the total data points. In contrast to the table for problem points, in the data points table, each of these categories may only be used once per visit. For example, if you review and summarize all data and obtain history from the patient and another party, this is still only a total of 2 points. The exception for some carriers is independent visualization of image, tracing, or specimen itself. If you personally visualize and interpret the EKG and the chest film, for example, some carriers will give you 2 points for each. WPS and some other carriers only just give a total of 2 points for this category. In any case, note that psychiatrists could get 2 points for visualizing and interpreting a rating scale that the patient brings in or fills out during a visit. The number of data points determines the level for the amount and/or complexity of data to be reviewed, with the highest level achieved at 4 points or more. Risk is the third element of medical decision-making. Risk could be that associated with a presenting problem, with a diagnostic procedure that is ordered, or with a management option that is planned. The highest level of risk determines the overall risk. Risk is defined by an extensive table. Yes, another table. It is still another table, but a large part of the risk table does not apply to a psychiatric practice. This is the condensed version with all you need as a child and adolescent psychiatrist. What you should especially know is that minimal risk is rare in child and adolescent psychiatry unless, for example, the purpose of the visit is filling out a form or something similar. Low risk includes one stable chronic illness. Moderate risk includes 2 stable chronic illnesses or one that is mildly worse. Moderate risk may also be prescription drug management. To qualify for this one, you should document active management, such as adding, stopping, or changing the dose of a medication, or the thinking behind keeping an existing medication at the same dose. High risk includes chronic illness with severe worsening or any illness that is a threat to life. High risk may also be drug therapy requiring intensive monitoring. An example is initiation of treatment with clozapine. Medical decision-making has 4 types: straightforward, low, moderate, and high. Note that only 2 of the 3 elements need be met or exceeded to achieve a specific complexity of medical decision-making. This is the same table using problem data points. This may be a bit easier to visualize. On to time. Time sounds simple, but is one of the more confusing components of E&M codes. Each code lists a typical time. When the code level is determined by key components, the typical time is just a guide. The actual time may be more or less. The system was designed to reward efficiency. If you are able to complete the required task in less time than the specified typical time, you still get credit for that level of code. There is no need even to document or track the time when coding based on key components. Now the exception. When counseling and/or coordination of care is greater than 50% of the time of the visit, time becomes the controlling factor. The code then becomes a time code, with the typical time being the total time required. Total time is measured differently for outpatient visits versus facility visits. The total time for an outpatient visit is the face-to-face time with the patient or a family member. The total time for a facility visit is the time spent on the unit or floor while engaged in activities for care of the patient, including care face-to-face with patient and/or family, discussions with staff members, phone calls related to the patient, and charting. Document total time for the visit, time for counseling and/or coordination of care, and the counseling and/or coordination of care activities. Note that for CPT, counseling is not psychotherapy. So, it looks like cognitive reframes are fully covered, interpretations require a 20% copay, and small talk is out of pocket. According to CPT, counseling is a discussion with patient and/or family concerning one or more of the following areas: diagnostic results, impressions, recommended diagnostic studies, prognosis, risks and benefits of management options, instructions for management and/or follow-up, importance of compliance with chosen management options, risk factor reduction, patient and family education. For years, your teachers kept telling you to settle down and sit still. You can stop now. This is counseling. One of the problems is we have 7 different E&M components. How do you make sense of what to use for a particular visit? Think of medical decision-making first. The E&M level for the typical visit, acute medical problems or management of chronic conditions, should be driven by the complexity of medical decision-making. After determining that complexity, then document at least the minimum levels of history and examination required by the code. The history and examination serve to support the medical decision-making. There are exceptions when the work of the visit is not accounted for by medical decision-making. Common exceptions are reevaluation for patient returning after a gap in treatment, stable, single diagnosis of problem, but still requires monitoring for comorbidities, complications, and side effects, and counseling and coordination of care predominate the visit. Please tune into the next E&M webinar for illustrations of these coding principles with patient examples. One more term, some codes are differentiated based on whether the patient is new or established. A new patient is one who has not been seen for any professional service in the past 3 years. Seen refers to having received services from the physician or another physician of the exact same specialty and subspecialty who belongs to the same group practice. A covering physician is considered as having the same new versus established status as the physician who is being covered. Congratulations, you have now seen the structure of E&M coding. We welcome you to view other ACAP presentations for application of specific E&M codes to patient examples and other CPT coding topics. Send any questions for us to Jennifer Medicus at jmedicus@acap.org.